So thanks very much, Suganya. So we're now shifting from India to Nepal and sort of shifting. I think Suganya's presentation was a really nice transition from thinking about access and equity, and our remaining presentations are now thinking about quality and monitoring outcomes of cataract surgery. So it's a real pleasure to introduce Reena Yadav, who's a cornea specialist here from NNJS. And Reena's going to be presenting some work that she recently completed as part of her master's. So thanks very much, Reena.
Thanks, Jackie, for the introduction. And I'm here to share my findings on evaluation of cataract surgical outcome, which was done in a high-volume cataract surgical center in eastern part of Nepal. And looking at the cataract surgical coverage and effective cataract surgical coverage of Nepal at 618 threshold, the CSC is 69.2 and ECSC is 57.6 with the relative gap of 16.7. Now we have the data at 612 threshold, and as we move to the 612 threshold, the ECAC has even dropped down from 57 to less than 50%. And as WHO has shifted to reduce the postoperative visual acuity acceptable threshold to 612, and for the country like us, where SICS is more compared to phacoemulsification, so keeping that in mind, we wanted to know that what are the proportion of people who have undergone SICS have a PVA of 612 or better in the operated eye 1 month after surgery, and if not, what are the reasons? So this study was done in Sagarmatha Choudhary Eye Hospital, Lahan, in a patient from Sirah and Saptari district of Nepal, aged 40 and above. And combined procedures and other comorbidities were excluded, like lag of thalamus and squint, but not diabetic retinopathy, glaucoma, and macular pathology. So we recruited 340 consecutive patients who underwent SICS at SCH, and among them, 81.1% completed their 1-month follow-up. And among them, 272 had complete data and entered into analysis. So among them, more than 50% of them were female with a mean age of 65, ranging from 40 to 97 years. And most of the participants, that is more than 90% of them, did not receive any form of educations, and more than 50% had coming from farming background. And there was interesting finding that 68.7%, that is more than half of them, chose SICS to phaco because of the cost reasons. So now evaluating the causes of PVA less than 612 at 1 month, 96, that is 35.3, managed to have a PVA better, 612 or better, but more than 50% were in a group with uncorrected refractive error, with rest other causes like complications of surgeries, posterior segment pathologies like diabetic retinopathy, macular scars, and glaucoma, and corneal scars. But if we plotted this against preoperative PVA to 1-month PVA, so there was only 35% of them were under this region, that is the red line, 612 or better. So only 35% were in that category. But the ray of hope came when with only just glass correction, it moved, the number increased, like the number of dots increased in that area from 35 to 90%, which was quite encouraging. And on factors evaluating BCVA less than 612 at 1 month, there was on multivariable logistic regression, age, ocular comorbidities, and complications were significantly associated. And looking at the preoperative and 1-month refractive status, we managed to increase the emmetropic patients from 31 to 70%, while decreasing the myopia state from 65.8% to 29.8, and mean spherical equivalent from -1.8 to -0.6 diopter, and the mean spherical power from -1.7 to 0.1. But the mean cylindrical power, it increased from -0.04 diopter to -1.4. And there were only 2.2% of the patient with had astigmatism before surgery compared to 1 month, that is 75.3%. But there were some cases with measurability variations due to cataract before surgery, but a lot of them were induced astigmatism as the technique, superior technique, incision technique was adopted in more than 90% of the patients. So what we learned from this study was residual refractive error was common and there was increased astigmatism. But we learned that we want to emphasize here that, and we came to know that without integration of cataract service and refractive error correction service together, we will not be able to achieve what we aim to and for the target given by WHO. And a slight modification by the surgeons from shifting from a superior approach to a temporal approach would definitely lead us to the target given by WHO, and overall it will help to increase the ECSC. So that's all. Thank you. And the floor is open for the questions.
Thanks very much, Reena, and congratulations, because I feel like there's a real interest. That figure showing by the impact of correcting the refractive error. I think there'd be a real interest. I think from a WHO perspective globally to make that really strong case between the connection between if we improve ECSC and EREC, they're really closely connected. So congratulations, and really looking forward to. I know you've just finished, but if you can get this published, and I think it will be very useful for us. So Parikshit.
In this, you said that because you're doing SICS, a lot of them need refractive correction because the astigmatism is more than 1 diopter. So their unaided vision is less than 612. Yes. But like we do phaco on all our private patients, and we are very happy. Next day they are 6.9 or 6.6. But quite a few of them are not happy because they said earlier we could see a mobile or we could read the newspaper, which we are not able to do now. So in a way, it is the surgery has caused the astigmatism, so it is iatrogenic. But have we also looked at the fact that we are always looking at unaided distance visual acuity? But for most patients, it is their intermediate or near vision that is very important. And when we are doing SICI surgery or any surgery in which even if there is a small residual error left, as long as it is a minus error, it helps them in their near vision. Yeah. So the next time when you do it, we should look not just for distant vision, but we should also look for near vision, because that is also equally important for the patient.
Yeah, absolutely. And it should be customized for all the patients if possible. It is not possible, I agree, in a high volume center, but if it is customized for all patients, their individual need, that will help us achieve.
Yes, but most of the patients that are there, which are operated in CAMS or at the lowest, there's the free surgery, they are more likely to be older, they are more likely to be women, they are more likely to be older women. And a lot of them would want a better near vision than a distant vision, because very few of them would actually drive or, do stuff which needs very good distant vision.
Yeah, absolutely. I agree with that.
Simon.
Yeah.
Thank you, Reena, and congratulations. I wanted to know the people who needed glasses, did they receive them? What's the uptake? And what are the, things which allow that conversion to happen? Oh,
thank you for asking me the question. Because of time constraint, actually this was a mixed study. I have collection of data, qualitative data, where I evaluated the uptake of residual refractive error correction after their surgeries. The most common cause, like most of the patient, they did not want glass, and most common cause was the cost. They wanted the glass for free. They said that if it is provided for free, they were willing to take it. Otherwise, they won't. And most of them thought that if they start using glass for once, they need to visit the eye hospitals again and again every 6 months, and then so. What two conclusion I draw from that is like, one, that it should be integrated in the package, like the glass not giving them in the whole cost, including in the surgical cost, so that they would not feel that it's coming apart from that. And the other is that they need the refraction service should be available near to their local resident area, like in health post and all. That two things that they brought up could help in the uptake of glass. Thank you.
Thanks very much, Reena. That's great.